We are live.
Good evening. Welcome to iFocus Online. This is a special episode. This is the 500th episode of iFocus. iFocus started about 5 years ago as a catalyst for change. This was during the COVID times. We already had iFocus, physical iFocus for 10 years, and it was being attended by more than 300 to 400 delegates each year. Those were some of the physical iFocuses that we conducted before COVID. COVID changed it all, and Dr. Mahipal had a brainwave. He wanted us to do iFocus online, which was a virtual version of iFocus physical. So we did a brief survey and found that about two-thirds of residents were not getting enough teaching during COVID times, and that started it all. In fact, we followed the AIOS national curriculum and also amalgamated the ICO residency curriculum to teach according to these two curriculum, which would obviously mean that we would cover the most of ophthalmology. In fact, the first lecture was delivered by Dr. Mahipal himself on June 3rd, 2020. That was 4 years, 11 months ago. And by now we have completed 499 episodes, and today is the 500th episode. And as you see here, we have more than 31 lakh views and more than 30,000 subscribers, and it's become the gold standard of ophthalmology. And Dr. Mahipal's first lecture has garnered about 33,000 views that was streamed more than 4 years ago. And today he's back with the 500th lecture. Welcome, sir, and I would request the team to take over and introduce Dr. Mahipal.
Good evening, everyone. I welcome you all to today's special edition of iFocus Online session. As we all know, it is the 500th episode of iFocus Online. Let's proceed with before we proceed with the class, let's have a quick peek into the iFocus journey, a small gesture. So today is a special episode, not just because it is episode number 500, but also because we have two masters in one screen. Our chairperson, Dr. Sri Ganesh sir, chairman and director of Nitrodama Group of Eye Hospitals, and Dr. Professor Mahipal Sachdev sir, one of the pioneer in refractive surgery, chairman and director of Center for Sight Group of Eye Hospitals. Welcome, sir. Sir is going to teach us about the evolution of calyx from infancy to coming of age. We are honored to have you here, sir.
Thank you.
So to moderate today's class, we have Dr. Tulika Chauhan, ma'am. After finishing her fellowship in FECO from Venu Eye Hospital, in anterior segment from Vasan Eye Care, she did her fellowship in cornea and external eye disease from Massachusetts Eye and Ear Infirmity, Harvard University. She did a clinical and research fellowship in cornea and refractive surgery from Stein Eye Institute, University of California at Los Angeles. She has held a research scholar in cornea and glaucoma service from University of Mainz, Germany. She has a certification in management of low vision from LVPI Hyderabad. Currently, ma'am is a senior consultant in cornea, external eye disease, cataract, and refractive services at Center for Sight Eye Institute, New Delhi. Also, she's a fellowship program coordinator at Center for Sight, New Delhi. Ma'am has numerous publications to her name in prestigious national and international journals. She's an editor and reviewer of AIOS, ARVO Journal, TVST, CJO, DJO, DOS Times, and Curious. She's involved with clinical research and trials as well. Over to you, ma'am, for the introduction of our respected chairperson, Dr. Sri Ganesh sir, and our speaker, Professor Dr. Mahipal Sachdev sir.
Thank you, Kritika. Thanks a lot. It's indeed our pleasure to have Dr. Mahipal Sachdev and Dr. Sri Ganesh on one screen. They're the pioneers in the field of ophthalmology we all know for this iFocus 500 Gala episode. It's my true pleasure to introduce leaders and pioneering figures in refractive surgery, whose contribution we all know have shaped modern day ophthalmology. Their work has not only elevated clinical standard, but also has inspired a new generation surgeon. So, Dr. Sri Ganesh doesn't need any introduction. He's a chairman and managing director of Netradhama Super Speciality Eye Hospital, and he has various award recognition to his name. To name few, Colin Rangachari Award for overall best paper in AIOC, AUCRS Gold Medal Oration Award from D. Graham Barrett, Michael Kritzner Award by International Society of Refractive Surgery at AAO. He has more than 100 plus publication in peer-reviewed international journal refractive surgery. I welcome Dr. Sri Ganesh for chairing this session. Our esteemed speaker, Dr. Mahipal Sachdev, he doesn't need any introduction. He is Padma Shri by President of India in 2007. His awards cannot be listed on the screen, so it's just a small introduction from our side. I'm happy to introduce both the leaders, and may I request Dr. Mahipal sir to share his insight into keratorefractive lenticule extraction. Over to you, sir.
Thank you. Thank you very much. Welcome everyone to the 500th episode, and thanks and kudos to Dr. Santosh, who has been doing this relentlessly over the last close to 5 years now. And as is evident by the popularity of iFocus, I think we are happy that there are lots and lots of people who do tend to join in. And we shall be holding our physical eye focus also. The dates will be announced soon by Dr. Santosh in Delhi. So without much ado, I'll just wish to make my presentation, which is on a subject, maybe what Santosh said. I started with phacoemulsification, and this is another subject which is very close to my heart, and that is the refractive surgery. And thanks, Dr. Shri Ganesh, for joining in, because he's also a pioneer in the field of refractive surgery, and more so in the field of keratorelenticular extraction. So I'll be talking about the journey of Calyx. Calyx is the word that is used today and is a nomenclature that is for any lenticular extraction based refractive procedure. And I'll be talking about how it has come of age vis-a-vis from when it started. So when you look at the entire gamut of laser vision correction or from that matter, any refractive surgery, the first published experimental study on refractive surgery dates back to 1896. And it was in 1930 that radial cuts were performed by Sato. And that was the first time, though he was doing it from the inside, and it led to a lot of corneal edema. So it went into disrepute. And then you had Fidorov coming in. But when you when you looked at the issue of reshaping the cornea, not by making radial cuts, it was Barakar who began to apply this procedure, and this was called as keratomileusis. Kerato, as you all know, understand, is cornea. Mileusis is to reshape the cornea. Theo Seiler and Srinivas, these people were working on the excimer laser for etching the computer chips. And the first PTK was performed by Theo Seiler. And then on, it went on to the first PRK, successful PRK on non-sighted eyes was done by Margaret MacDonald. But from the PRK days, one went on to the word LASIK, which was coined by Pellicaris. And this was making a flap and then doing an excimer laser. And this went on with the Radke Trop performing the first femtolasic, which was there. Secondo performed the first smile procedure. And the way smile is done today, that was performed by Dr. Rupal Shah in India. Market introduction of Smile, and then there are more than 100,000 Smile procedures that have been done in the year 2014. And from there on, the journey of the commercial procedure of keratorelenticular extraction went on. So when you look at the various types of experiments that were done, these were animal experiments on rabbit. So you can see Blum, Secondo, Titson. These were at Carl Zena, physicist, working on this. And this is how they started doing it on animal models, the animal experiments which are there. And the piglets were then later on done. And you can see here, these are the experiments that were done with the femtolaser to make a lenticule 2004, 2005. Then there was a clinical evaluation, and this was presented in American Academy of Ophthalmology. This was later on after 2005 that the clinical evaluation was done, where a contact glass evaluation of 50 normal eyes, and these were on students of School of Optometry, that they looked how to dock onto the patients which was there. The human trials then started in 2005, 2006, and this is the first, at that time, there was no pentacam. And this is the initial first thing which was there, that this is how the map looked before and after, which was there. And this is how the machine that was being worked upon, this is how this box looked like this. And these trials, there were treatment of 5 blind eyes, and that was 4 eyes post CRVO and CRAO, and 1 eye with a glaucomatous optic atrophy. Then what was followed was the amblyopic eye, and the first seeing eye was treated on May 3, 2006. And that's the time this was in Ofra at 4:20 p.m. This was the first treatment that was done. So there is a lot of work that went on. And 2006 was a busy year. So first they started with what was known as a femtosecond lenticule extraction, where a lenticule was created, but also a flap was created, and then the lenticule was taken out. And this was therefore a similar procedure to LASIK, but with a flap and a lenticule being taken out rather than an excimer laser being used to burn the cornea, and then the flap was put back. So this was reported in JCRS in 2008 by Secondo, and also was presented in American Academy of Ophthalmology. So this was in November 2006 in Las Vegas that this was presented. And you can see that this is how they said about the femtosecond laser, a flap being created, a lenticule being created, a plano-convex lenticule, and then the lenticule being removed. And they said that we can do away with the excimer laser by taking this particular technique in the form of just a femtosecond laser to do the entire procedure. Now, the first Mesovax in this design was released in the 2006, and this was where it was looked at a lenticule being taken away. Then after the flap, it was really then making the incision small to make it a small incision lenticule extraction. And this is the first lenticule extraction that was done thanks to Dr. Shah on lenticule studio. And you can see basically the pseudo smile, as they said. You can see it's slow moving laser. Look at the speed now. And there were several refinements that were done. You can see this is the laser that is passing on. And the time taken was pretty long, more than a minute that was taken in this case. And as you can see that what happened was that and then again it was coming center, and this was not giving great results. So again, it was a thought process that came in that rather coming back from the rather much time and here to expand in the center, why not first see that again it was and that helped the and you can see that even first thing that is there at the lower part, but this is now just smile was done. And again, the proud moment that we have to the first smile procedure that was done globally. Now, let's just move forward from here. and let us see what all has moved on from there. This was performed by Rupal, and more people came on board, and these were the early adapters. Osama in Egypt, then you have Mayer, Wilflang in Germany, Dan Ranstein, Ektet Chensui in Thailand, and Jesper in Denmark. The Chinese stepped in and brought enormous numbers. As you all know that China does enormous numbers. And from 200, it was upgraded to 500 kilohertz, and that is in 2009, which was there. And 2011, the official market introduction of the Smile was done at the ESCRS, which was there. So Smile was initially just a possibility, and that was a paradigm going on from the Excimer to the Flex, and then moving on from 200 to 500, and now Visumax Pro is at 800 kilohertz, and then the scanning pattern has been reversed. So it's a reverse scanning pattern which is there, and it is now giving high energy with lower spot and track spacing. So whenever the laser hits a particular point, you have to have spot and track spacing, and that can be altered as regards the individual laser as to what is the glass burn threshold, and accordingly you can alter the energy, and you can make the line and the spot separation which is there. The trials which are going on, the second prospective trial for spherocylinder Y-flex procedures was the MEL 90. The first trial was in 2008. That was the hyperopic treatment, and this reduced the treatment time to 32 seconds despite the big zones. And going ahead, they have performed these hyperopics, Kishore Pradhan, Dan Ranstein, and now Dr. Shri Ganesh has also, and I think it's going to be commercially available, the hyperopic treatment. So as of now, the lenticule extraction is available for myopia and myopic astigmatism, but not available for hyperopia. Now, as one says, one shouldn't look back and ask why, but look ahead and ask why not? Why not we can do these things? So as one moved along, what is happening is that there were these commercial lasers that were available, and they were all coming with different names. So the scientific nomenclature of keratorefractive lenticule extraction procedures, there was a joint editorial statement in 2023, and this was given the name of KLEX, that is keratolenticular extraction, which is there. Now, let us look at the various lenticular extraction platforms which are available. You have the Visumax 500, which is the earlier version. Now you have the Visumax that is called as the Smile Pro. This is the Visumax 800. You have the LDV, that is the Z8 for the Zemer. And then you have the ATOS, which is the Schwinn machine. And then you have the Elita, which is the Johnson Johnson. Now, if you look at the wavelength, it is the same, about 1040, which is across the board because it's the same type of infrared laser which is there. However, what makes the difference is the laser pulse repetition rate. So if you look at the pulse repetition rate, you can see that the fastest lasers are the Zemer and the Elita. And then you have the Visumax, which is there, and then you have the ATOS Schwinn. So these are the lasers which are the repetition rate as to how often the laser fires. And as you see over time, there is an attempt to reduce the amount of energy per pulse which is there. So the amount of energy, the least amount of energy that is available per pulse is the in the Elita, which is 50 to 70 nanojoules. Now, the cut time has been reduced significantly from the 500 Visumax, which was about 27 seconds. It has come down to 10 seconds, which is the fastest laser today, which is the Visumax 800, and about 16 seconds, which is in the Elita Johnson Johnson Vision. Patient interface can be different, and these are curved in 500, 800, and in ATOS Schwinn. However, the patient interface are totally flat in the Z8 and in the Elita Johnson Johnson. Now, when you started, there were two things which were a problem in the Visumax 500, which was that you could not do a cyclotorsion compensation. Though Dr. Shri Ganesh has defined marking it and doing a cyclotorsion compensation. In the 500, it was not auto, and there was no centration system. That means that if you were docking at a wrong place, you would have had to remove the suction and again redock to get onto the center. However, this has been taken care of in the Visumax, also in the Z8, also in the ATOS, and also in the Alita Johnson Johnson. So you have these two problems that have been rectified, and that is your ability to center post docking, and also the ability to do a cyclotorsion compensation. If you look at the geometry of the lenticule, there is a side cut which is available in all except in the Zemer. So these people do want at time to have two entry cuts, one merging with the superior and one merging with the inferior part of the lenticule. Now, when we come to this, where we have personally been involved, that is at Centrifocide, and that is the ELITA system, which is the SILK, which stands for Small Incision Lenticular Keratomileusis. This is a new investigational femtosecond laser design, which is still not approved in the US by FDA. I think the Smile Pro is also not approved by FDA. Neither is the Zemer, nor is the ATOS. So FDA is a little slow, but however, in the rest of the world, this has been these machines have been approved, and they create fast and smooth cuts for easy lenticular absorption. So 2018, this again has taken several years for it to become commercially available, and the first data was fired.
Ready? Ready.
Fired for the first time in lab trials on the lab, so that lab the first flap procedure. The first silk procedure, as things stand today, was done during the COVID times, and this was 4th January 2020 at 4:32 in the afternoon. This was just before the lockdown that happened in India. And this was again performed in India, again a proud moment for Indians to do these particular things. The results of the silk procedure have been published in clinical ophthalmology in 2024. And if you look at the results, we'll first show you the procedure. As you can see here, this is after docking. We can change the centration, and you can see that you mark the cornea, and you can change the cyclotorsion. So this is the important thing, that centration and cyclotorsion can be changed. Once it is ready, you can see the optic zone is being shown, the total zone of 7.6. This is the entry zone. And you can see that how fast the laser is moving. This is about 16 seconds, as you can see here. Side cut has happened. Now this is the top cut that is coming in. Once the top cut has happened, you can do an entry cut. I normally prefer to do it at about 3 millimeters, but you can go down to 2 millimeters in the entry cut, which is there. This is how it looks. This is the undocking after the laser has been fired. And you can see that because it's a biconvex lenticule and not a plano-convex lenticule, you have to go up a little bit to enter into the anterior plane, and then you go down posteriorly to go below the posterior plane. Once you have done, because there is no line and no spot separation in this particular laser, you can actually go ahead and do the dissection in almost, you can say, a minimal or no dissection. And the outcomes are pretty good as regards, we'll be talking about the outcomes as regards the separation. Normally, there have been very few instances that have been reported about retained lenticule, which is there. And you can see that we can go ahead and remove the lenticule with very ease and precision, as you can see in this particular case. And that's the lenticule. This is coming out very easily. Now, let us just talk about a little more about the profiles that you have on the lenticule. So when you look at the ELITA, this is creating a fast and smooth cut for easy lenticule removal with this symmetrical anterior and posterior lenticular surfaces. So you can see here that this is a biconvex lenticule, and the refraction is therefore on the biconvex lenticule, and these are symmetrical. Patient interface is flat, and it makes the whole thing flat. This is the optic zone. This is the side cut that you can see. This is the total zone with the transition zone. And this is the entry incision, which is there. Now, what makes this good is that the laser pulses, if you compare it with the IFS, that is the intralaser femtosecond, you can see that it fires for 600 to 800 femtoseconds. However, the ELITA laser is down to only 150 femtoseconds. So the pulse hits for a very, very short time. The other thing is that it gives you a tissue bridge-free dissection. This is a tissue bridge-free dissection because this is a continuous surface scanning. It is scanning the surface continuously with only energy of 40 nanojoules and no spot separation, which is 1 micron spots, and this is hitting next to each other. When you compare it with the IFS, this was spot-to-spot separation was 7 microns, and the spot was about 4 microns. So you can see that this is the difference between the contiguous spots and the spots which were there earlier. Now, the optical quality of the numerical aperture, etc., of the optics is so good that it is giving you a auto Z detector so that it hits properly. There is a high numerical aperture focusing optics which can focus very precisely through the patient interface, and it gives you a good, secure, auto-calibrated patient interface. The patient interface is calibrated before you actually start to fire. Now, let us look at the CLEAR, which is the corneal lenticular extraction and advanced refractive procedure by the Zimmer Z8. You can see that there are two incisions, one incision which is going on the top and one which is going on the posterior plane. There is automatic compensation for cyclotorsion. In the earlier one, you could see that it was, you had to mark it. And there are different centration options. You can either center it on the pupil, you can center it on the fixation light, or you can do a corneal marking and then fixate and do the cyclotorsion adjustment. So this is how the machine is. This machine also gives you the ability to do a cataract procedure or femtocataract procedure on it. This is the Visumax 800, which Dr. Shri Ganesh has worked significantly, and you can see this is one of the most grand looking machines. As you can see, next generation machine, this is how it is. And you can see that this is a cyclotorsion compensation which is there, as also there is a centra aligned system for easy centration. So you can see you have to bring this dot here and then it takes on in the centration and the cyclotorsion compensation that has happened in this particular case. Now, let me come on to, after having described you a couple of machines which are there, then let us come on to the dissection techniques which are there. How do you improve the dissection techniques? How do you address astigmatism? How do you tackle complications, circle software, and innovative uses of lenticule? So this is next clinical part of the technique, etc., that I'm going to be talking about. Now, when you are looking at the dissection techniques, the key here is to enter the two planes. The first thing that was described is called as the meniscus sign, wherein you can see that you are getting like a meniscus here. This is a meniscus which is there. And then you have going into the upper and the lower part, and you can see this meniscus very clearly. And if you get this meniscus, that means that you are in two different planes, which is there, described by Titial et al. Now you have a white ring sign which was described by Susan Jacob et al. So you can see that this is a white ring. This is a white ring. And if you are below this white ring, then you are sure that you are in the posterior plane, which is there. So this is one of the other signs which is there. This is a stop sign which has been described by Gitansha Sachdev et al. And you can see here that if you are in two different planes, there is a resistance. So you can see that this is going in one plane and this is going in another plane. So you see there is a stop here. That means that stop sign demonstrates that there are two different planes. That is there. You can see there is a resistance. And if you are in the same plane, you will not get the resistance. Now, let's come to there's another sign or another way to remove the lenticule that has been described by Dr. Shri Ganesh, which he calls as lenticuloschisis, where he does like a capsulorhexis to remove the lenticule. Now, let us come to innovative uses of lenticule. If you are looking at how you can use the lenticule, we have what is known as tailored stromal expansion. We have described that in the year 2015, wherein we are using the lenticule to increase the thickness of the cornea for cross-linking in cases of thin corneas in keratoconus. So what we do is that we are making we are taking a lenticule from another patient, and after this lenticule, we put it on top of the cornea in the case of keratoconus, so that if I want, say, 60 microns, I would be working with a 3.5 diopter lenticule with the table, which will be giving me about 60 microns of tissue, and then I'll be putting it and doing the cross linking and removing the lenticule at the end of the procedure. So this is going to typically expand the corneal stroma for the limited time of period that we want, which is there. So let us just run through this procedure on the innovative use of this lenticule. You can see that we have removed the epithelium. This is the lenticule that is being taken out. Once you have the lenticule which is taken out, we'll just take out the lenticule and put it on the recipient. That means for the temporary increase in the thickness. So you see, we put it. The biggest advantage is that it doesn't warp like a contact lens. It fits exactly on the thinnest part of the cornea, and you can measure as to what it is. You can soak the lenticule into in the riboflavin, and you can see that the lenticule is removed after the cross linking has been done, and then you wash it and put a bandage contact lens, and that would be the end of the procedure. We have shown excellent results on this. You can see pretty well. Now let us come to certain problems which you can see. This is a retained lenticule that you can have. You can see that you can see it well. If you do an OCT, you can make out that there is a retained lenticule. And on retro-illumination, you can see well. On topography, you can see that wherever there is a retained lenticule, there is going to be a steeper cornea. So this problem does happen if you have uncut areas, and maybe for beginners, you could have visualization at least to begin with, to be having a problem as regards the visualization. So one has to be careful that the lenticule is taken out in toto and not left behind, because this is going to cause irregular astigmatism and cause problems for the patient which is there. Now, let us just show you how you work. So if you are patient and you can see that there is a retained lenticule in this particular case, you can see that there is a retained lenticule. If once the hydration has also been done, can you make out that this is the portion of the lenticule? It has been removed only half. Under these circumstances, you can go ahead and be very, very careful. See, this is the retained lenticule. So even if there is a hydration that is done, you can, and this is with the retro elimination, you can see easily that one can see as to where the lenticule is, and then you have to keep trying to grasp it and to remove it. And you can see, if you are able to grasp that particular area, you will be able to remove the retained lenticule. It's just a matter of patience, and you can see how much of the lenticule has been removed as it was earlier, and this would complete the earlier lenticule. A slit lamp would help you identify whether there is any retained lenticule or not. Now, again, Gitansha Sachdev et al. Have described the use of tramsulocin, which is tricot. You can dilute tricot 1:1, and you can put it into the interface, and you can see that this is a retained lenticule portion which is there. And the retained lenticule, because of the visualization, some people have also described the use of sodium fluorescein. You can do anything that can help you identify the lenticule, can help you do this. Now, the intraoperative ASOCT has also been described to see as to where exactly the lenticule is. You can also use a circle scan. This was described by Tityal and Dr. Shri Ganesh. The circle software was described by Dr. Shri Ganesh for the management and for the management of retained lenticule. That means that you can make the cap into a flap and then take it out. Now, apart from the innovative use that I have talked about, we can use this for thin cornea. This has been published in AGO, where we have seen the effect of Intacs along with the corneal cross-linking in thin corneas with the use of the lenticule to increase the corneal thickness which is there. Now, again, Dr. Shri Ganesh is here, so he'll be also in a better position because he has done the study wherein he has called is that FILI, which is femtosecond intrastromal lenticule implantation. This is for hyperopia. This has been reported by Dr. Shri Ganesh and Dr. Barar. You can see here, this is the lenticule. He picks up the lenticules from the myopes, and accordingly, as per the calculation, he will put it after making a pocket into the pocket so that there is the hyperopic correction that can happen. Again, Dr. Shri Ganesh has described the use of lenticule for the fili for keratoconus, that is the intrastromal lenticule extraction that is there. As you can say that if you are adding tissue, the things can improve significantly with this lenticule. So you have these other innovative uses that you have with the lenticule, that one can go and use this lenticule for other problems, other issues to be addressed. That is for hyperopia. You can have it, as I told you, for again, for the keratoconus patients also. So friends, these are a couple of the things that we have been talking about, and the results of the various procedures are pretty good. You can see that we have had excellent outcomes with the procedures. The couple of things that you have to remember is that there is a nomogram adjustment that has been done for almost every machine, whereas a slight amount of overcorrection is required for getting bang on, specifically in higher myopes. But those are nomograms which have been made by various authors or various surgeons, and that is giving excellent results both for myopia and hyperopia. One important thing for you to understand is that when you are comparing a lenticule with the excimer laser, the environmental conditions do not make a difference as regards the burn of the cornea. It is basically the numerical aperture and the focusing mechanism which is going to help you get to the desired results. And the number of retreats that are there, which have been observed by various authors in cases of lenticule extraction, are far lower than what you have in excimer, because you can tend to have the cosine effect also of the excimer, while you do not have that in the lenticule extraction. And the outcomes are more stable in the lenticule extraction as compared to the other, that is the LASIK procedure. Apart from that, as you all understand that the corneal nerves are coming from the periphery. If you are making a flap, the corneal nerves will obviously get transacted at say 8.5 millimeter or 9 millimeters, depending upon the flap that you are having. And the incidence of dry eye is much lower or much lesser in these cases as compared to the flap-based procedure. So stability also, there are no flap related complications which are there in the lenticule procedure as compared to the flap related procedures. So overall, I would say that this is something that is being in the Asian countries, I think, and in Europe, lenticule has really graduated to a position of strength. US, I would say, is lacking behind because they don't have access to the newer forms of the lenticule. Earlier trials were also done without astigmatism being more than 0.5 and the correction not being able to do. So therefore, the results were slightly indifferent. Also, they were not able to play with the energy. It is very important in a femtosecond laser to be able to play with the energy, to reduce the quantum of energy to the bare minimum where you get the best separation without burdening the cornea with excess amount of energy which is there. So the world of refractive lenticle extraction has and is undergoing drastic changes. And from a radical idea, as I told you, for refractive correction to taking flap-based procedures head-on and ultimately giving better, if not as good visual outcomes, I think that is what the lenticule-based procedures have been able to achieve. This is no longer a monopoly, and there is a stiff competition in the market with different platforms which are offering you good results, and with better laser platforms and flatter learning curves. This is something I think there was a lot of noise about it having a long learning curve, I think that is also something in the past. The learning curve is much, much lower now as things stand, and there are these videos, etc., to watch. The energy optimization is much better, spot line separation is much better, and you can get good refractive lenticule extractions, which I feel is the way to go forward. And refractive lenticule extraction is here to stay. In the refractive lenticule extraction, if you look at the drawbacks, the first drawback is that as things stand today, maybe in couple of months, we'll have the hyperopic correction. It does not have hyperopic correction and compound number correction. The second thing is that if you are to retreat a patient with a lenticule, though there have been some studies and work to do a lenticule again on a lenticule, as things stand, you will either have to do a surface ablation or make the cap into a flap by doing a circle scan and then using an excimer laser. So the excimer laser is not totally obsolete just now. It is still required in cases of hyperopia. It is still required in cases of retreatment. Also, the excimer laser is required in cases of topo-guided laser corrections. For example, if you are working on a case of TCAT or TREC, which is for the correction of or smoothing of the cone in a keratoconus patient. So overall, I think refractive surgery has made significant progress, as also the lenticular part in the refractive surgery has also made significant progress, and it occupies center stage today as one of the preferred positions for all good refractive surgeons to have in their armamentarium. So, friends, this is just to show you how over the last 20 years, the refractive surgery platforms have moved on in the lenticular-based extractions. And let's take technology and let technology take you forward. I would say that this is tomorrow. There is talk of having wavefront guided or based on the abrasions, doing modifications in your lenticular extraction and combining the topography also with the lenticular extraction. And that is how things are going to move in the future. Thank you very much for your kind.
Thank you so much, sir, for such a wonderful talk. May I invite Dr. Sri Ganesh to share his insight on the topic?
Thank you. Good evening, dear friends. And at the outset, I would like to congratulate Dr. Santosh Anawar and Dr. Mahipal Sachdev on the iFocus platform and the 500th lecture. And I think it was quite comprehensive, and Dr. Mahipal covered most of the topics on KLX, including different machines and techniques and other uses of lenticule. A few things that I would like to add is that the difference between the different platforms. Now, the Visumax 500 and the 800 are the only lasers with full field scanning, whereas all the others use partial field scanning. That means they scan a small part of it, treat, move on, and then again scan and treat. Whereas with the Visumax, you can scan the whole area and then treat it. So that offers a few advantages, but it needs heavier optics and more expensive optics. Outcomes are better when you have a full field scanning laser. And the US FDA again has approved both the Visumax 500 and the 800. The 800 also is approved in the US now, and it's becoming more popular. But on the 800, they have not approved the flap. It was supposed to during this ASCRS, but I think it will take a few more months. Hyperopia again is released, is CE approved and released in Europe. And in India, the registration is happening, and anytime in the next couple of months, we should have hyperopia available on the 800. As far as astigmatism and mixed astigmatism go, we have done cases of mixed astigmatism and even published the same in IGO. So mixed astigmatism can be treated very successfully with SMILE, and with the 800 now with the Ocualign, which is cyclotorsion compensation, you get excellent results for cylinder also. So overall, the KLX results have been pretty good. We have two platforms. One is we have the 500, we have the 800, and also we have the clear. And I think with all platforms, you get a fairly good refractive results. What varies is the day one results and the wow factor. And there are many ways in which you can optimize the energy to get better day one results. And this is something which is very important, optimization of the energy and techniques. Again, with the 800, you can have 1:1 or 1:2 spot spacing, which again makes dissection very easy. And you can just remove it almost no dissection technique. In fact, I presented this as a short video in the recent ASCRS, and it won the best high impact pearl. So again, by playing around with your track and spot spacing, which you can do with the 800, not with the other machines. I think you can do it with the 8-Os, but not with Silk and with the clear machines. So you can kind of optimize the energy to improve the dissection. And of course, I think we have had the other lectures on dealing with complications. I think I gave the lecture on dealing with complications of KLX and how you manage them. So each machine has its own characteristic, and then there is a learning curve. But most important thing is that you need to optimize the energy levels and learn the technique for a smooth dissection. Then the visual recovery also is good. And I think this is the future. In fact, KLX is the fastest growing refractive procedure in the world, and it contributes to about 35% of the refractive procedures, and it is growing. As far as SMILE is concerned, more than 12 million procedures have been done worldwide, and the other platforms also are picking up. Of course, like Dr. Mahipal said, many of them are not FDA approved. So with time, maybe once they get FDA approved, then the number of users in the US also will increase. But the 800 is becoming very popular in the US.
So,
Thank you
there
very
are
much.
a couple of questions.
Yeah. First question open for the house is from the PG. So our resident, Dr. Ishita, would like to ask first question. Ishita, would you like to ask your question?
Good evening, sir. Good evening, ma'am. So I'd like to ask, sir, what is the mechanism behind the dry eye symptoms getting better with the latest evolution of the CLEX procedures?
So basically, dry eye, the first thing, let's see fundamentally when you are looking at the flap that you are making, the flap obviously cuts at 8.5 or 9 or 9.5. And that is where the corneal nerves are coming from the periphery. So they transact the nerves right at the top. And because it is coming, the flap is coming from the top to the bottom. So it just cuts the nerves, and therefore you have more nerves being cut in the periphery. While when you are having a flap, it is cutting the nerves only at the entry, which is 2 to 3 millimeters, and the rest of the nerves keep going. So confocal microscopy and also aesthesiometry and other tests have shown that the dry eye are much less. And now when you look at a biconvex lenticule, if you just imagine a plano-convex lenticule, if it is plane, then this, wherever it is plane, this is where the nerves would be cut. But if it was a biconvex, the nerves would still have a longer period to transact, and therefore the nerves would stand much better. So again, these are studies that have been done in NN, where they have shown that possibly that the nerve regeneration as also the dry eye situation is better with a biconvex lenticule as compared to a plano-convex lenticule. So this is how it is improved.
Thank you, sir.
So Dr. Surveen has posted one question. Dr. Surveen, if you are online, can you ask
Yes,
your
yes.
Good evening.
Yeah, can I have the question?
So how can we recognize tap lenticular adhesion during the surgery, and how do we avoid it?
See, typically, when you're doing the dissection, there can be a tendency to get into the deeper plane. When you get into the deeper plane and dissect it, you think it's a superficial plane, and then you keep trying to find the deeper plane. and then you're not able to find the deeper plane. And some people actually dig into the cornea and create a false plane. So it's very important that if you're not able to find the deep plane, you are in it. That's the dictum. That if you cannot find the superficial plane, that means you are in the superficial plane. You have to find the deeper plane. There is a cap lenticular additions. For this, you will have to go with the short end of the instrument. You can either use a Chansey dissector or a Reinstein dissector. The short end you should enter at the incision in the track between the side cut and the cap cut. That means the area where between the cap and the lenticule side cut. Enter it sideways and then lift up and sweep up. And then you will enter into the superficial plane. And once you get the superficial plane, then you can dissect the superficial plane and remove the lenticule. There are several videos, and it's a good idea to practice this in the lab. So you deliberately go into in the wet lab, you can deliberately go into the deeper plane, and then you can use this technique to find the superficial plane. It's not actually a complication. It's just that you have dissected the deeper plane first, and you can recognize that, dissect the superficial plane, and then extract the lenticule.
So basically, when you're looking at also a biconvex lenticule, the only thing is that instead of going like this, you have to go like you are kicking a football. So you need to go up. And what Dr. Shri Ganesh has rightly said is that at the edge of the side cut, that means not the entry cut, but the side cut of the lenticule. If you go from the side and then go, you can easily trace back. Apart from that, you can use the micro forceps to actually peel it from the below. Like if you're holding it, you try to peel it from the top surface and you will be able to do that. The idea is to identify the side cut of the lenticule and to try to go into two parts. If you are moving around in the same area, try to move farther away and go from like a lateral movement and get into the top part of the lenticule.
Okay, sir. Thank you, sir.
Dr. Garvita, would you like to ask your question?
Good evening, everyone. I wanted to ask regarding the techniques of lenticular separation that are available today. For example, theoretically, there are a lot of techniques like lenticular slices where we use a forceps or using balance all solution for hydrodissection of the lenticule. But typically, for a beginner surgeon, what technique should be advocated for a lenticule separation?
See, basically, you will have to learn the classic technique. Use a dissector. I prefer to use the Reinstein dissector because it's spoon shaped, and don't use a very sharp dissector. The Chansey is a sharper dissector. Sometimes with a sharper dissector, you can get into a false plane, which you don't want. So the Reinstein dissector is good, and you use the short end of the Reinstein dissector to open up the incision first. And as a beginner, it's better to start with a 4 mm incision. And as you get more experience, you can reduce it to 3 or 2 mm also. So use the sharp end to open the incision, then you go upwards. Okay, once you go upwards, get into the superficial plane, dissect on the left half, you dissect the superficial plane, left half of the incision. And then on the right half, you go into the deeper plane, dissect the right side so that, like Dr. Mahipal described, there's a stop sign. When you move your instrument, the short end side to side, you will feel that it stops and you can't enter into the superficial plane when you're in the deeper plane. And when you're in the superficial plane, again, you cannot enter into the deeper plane. It just stops at halfway. So this is very important to appreciate so that you have separate entries into the superficial and deep plane. And then first you dissect the superficial plane. You have to go side to side, and in 3 sweeps, you can, the upper 1/3, middle 1/3, and lower 1/3, you can dissect the superficial plane. Then go into the deeper plane, and with a side to side movement, you just go to the 6 o'clock position. Once you reach the 6 o'clock position, then you move sidewards to the right side. And then it is always important to leave a bridge of tissue, okay, so that the lenticule does not fold over. It's called tachoing of the lenticule. So you should see that the lenticule does not tacho. Otherwise, you will not have any traction to dissect because you need some amount of counter traction to dissect. So you leave a small tissue bridge and then go to the other side. And when you're dissecting, if you actually reach the side cut and move along with the side cut, it's very easy to release the side cut and on the left side. And then you go to the right side and then push down to release the tissue bridge. Once you do that, then the lenticule is free. The lenticule is free from the side cut. Then it's very easy to extract. You can either extract it with the forceps, or you can even do what is known as an hydro expression, where you take a hydrocannula and then as you're injecting, the lenticule actually comes to the incision. Otherwise, what I do is I just go over the lenticule with the same Reinstein dissector and just put a little downward pressure and then pull it out and extract it.
And regarding BSS, it's been described very rarely because you don't get that kind of a free-floating kind of a lenticule. But if your dissection is very, very good, then you can just hydro express it. That's what has been told by certain people. But then you would be wanting to up the energy significantly, which may not be the best. So some tissue bridges, if they are left, that is the optimum energy levels that you are going to have for giving you clearer corneas on day one.
You cannot really do a hydro extraction because there will always be little tissue bridges, and then if you hydrate too much, then you're going to increase the corneal edema.
Yeah.
And day one results are not going to be good. What has been described by Janji et al. Is that after the complete dissection, once the lenticule is free and from the side cut and it's completely free, then you can do a hydro expression. You just go towards the 6 o'clock position and inject, and then it floats. But then ideally, we do not also want to wash the interface. There are several studies which have compared wash and no wash, and they find that not washing the interface is better for day one results. We also did a study, and now we no longer wash the interface.
Right, sir. Thank you, sir.
Thank you.
Dr. Kanika, would you like to ask your question?
Yes, ma'am. Good evening, sirs. And my question is for both the refractive giants. How far-fetched is the dream for a keratolenticule extraction for presbyopia correction, sirs? I know we've been talking about hyperopia corrections now. Is there any technique or any research going on the topic of a multi-planar lenticule extraction for some presbyopia correction?
See, there is a project going on called High Smile for presbyopic smile, where basically you're using the Malakara notation to induce spherical abrasion. Because with smile, with any lenticule extraction, because you have a very clear cut of the peripheral tissue, you don't have any induced spherical abrasion. That's what Dr. Mahipal also said. That's the advantage of Calyx, because it does not induce spherical abrasion, unlike LASIK, where you have the cosine effect, because the peripheral spots energy is less, so you get induced spherical abrasion. This is countered in wavefront optimized LASIK by giving extra spots to the periphery. But with Calyx procedure, you don't induce spherical abrasion. So but you can induce spherical abrasion by adjusting the defocus in the Malakara notation, and then you can induce some amount of spherical abrasion along with a mini monovision, like how you do Presbyon with the excimer laser with the MEL 90. Similar kind of a trial is going on, but I generally do not prefer Calyx for patients over 40 years because the cornea is naturally cross-linked, the tissue bridges are more, and what we have done is we have also compared younger patients and older patients and visual recovery with the objective scatter index with the HD analyzer, the OSIs, and it is in print. It's being published in the GRS. The first 1,500 eyes with the Visumax 800, where we have also looked at different subgroups, low myopia, moderate myopia, high myopia, and also younger patients and older patients over 35 and below 35. And we find that the objective scatter index is quite high and it takes more than 3-4 months to recover. So the visual recovery, quality of vision, contrast sensitivity is much lower when you do calyx in older patients. This is because the cornea is naturally cross-linked, and then when you break the tissue bridges, there's more irregularity in the interface. On any platform, it's the same. So I personally don't prefer to do calyx in patients older than 40 years. Even if that technology is available, it will be available in maybe like a couple of years where you can do a presbyopic correction with calyx. But the visual recovery, I'm not really convinced about it. I would still use the excimer laser because once you lift a flap and do the excimer laser, you get a very smooth bed. So this is the reason. This is my logic for not using calyx in patients over 40 years.
Thank you, sir.
Great.
So I have a last question for open for the house. That what is the experience with the regaining of contrast sensitivity as compared to calyx and the comparison between the calyx and the flap LASIK? So this is a question from our.
We have actually done a study, and like I said, it's being published, where we have looked at contrast sensitivity and also the objective scatter index. Now, why does the contrast come down? Contrast comes down mainly because of the irregular interface. If there is more scatter from the interface, then the contrast increases. Contrast reduces, and it takes about nearly 3 months or so. We have a publication in the IJO where we have looked at the interface by taking retroillumination photographs and graded it from 0 to 4. And you can use this as a template and compare the whenever you do a calyx and you dilate the pupil and take retroillumination photographs, you get granularity of the surface, and this granularity keeps on reducing. So it comes from usually what we have seen is it is grade 2 or grade 3. In bad dissections, it can be grade 4, or if the energy is not optimized. And generally, it comes to normal by about 2 to 3 months. But in older patients, and if your interface is irregular, it can take up to 6 months. And this again reflects on the contrast, and the contrast recovery can take up to 3 to 4 months normally. But if you have optimized your energies and your dissection technique is good, then even at 1 or 2 weeks, you have very good contrast sensitivity. And we have actually looked at that even with the 800 after optimizing it. We see that the OSIs typically are within 1.5 at 15 days. It's within 1.5, which is normal. The scatter is low, and the contrast sensitivity also is almost normal at 2 weeks. But this is what gives the patient satisfaction. It's not the 6x6, because most lenticule platforms, the refractive results are quite good once the nomograms are established. But what is important for patient satisfaction is the contrast sensitivity. So if you have good contrast sensitivity, then you have 6.6 and the wow factor, like what you get in LASIK. But if the contrast sensitivity is reduced because of poor energy or poor dissection, then the patient, though is able to read 6.6 or 6.6 parts, is unhappy. They say everything is blur, or there's a lot of night vision issues, or there is ghosting of letters. These are the complaints that are there. So it's very important to optimize the energy. And if you do the correct dissection, then the contrast recovers quite fast.
Thank you very much, sir. Such an interactive session and wonderful talk. So may I invite Dr. Santosh Hanawar for the closing statement?
Ma'am,
Sir is not there.
excuse me, ma'am.
Yes.
Hello.
Yeah.
Ma'am, I have a question for sirs, if I may ask.
Yes,
Yeah.
please.
Yes, ma'am. And the question is, sir, as we have talked about the evolution of calyx procedures, were there any changes made with the side cut as well?
So side cut, first of all, when you started, it was a full flap. Then they reduced the size, and then there were two flaps, two incisions. Okay, so that was 1, 2. If you have that was called as a rescue incision. That's how the smile started. That you could have an incision at the bottom, that there was a dissection, etc. And even today in Zemer, there are people who have two incisions, one going with the one merging with the superior part and one merging with the inferior. So I think that's what your question was, the entry wound, right?
Oh, her
The
question
side cut
was the
bone
side
geometry,
cut.
sir.
See, side cut again, see, basically the Visumax 500 has a side cut which you can adjust from 10 microns to 30 microns. And they have a patent on the side cut. So that's why the other platforms are not able to make a side cut which you can change. So with the Visumax, its minimum is 10 micron side cut, and it goes up to 30 microns. We have actually done a study, the zinc study, which we will be publishing, where we have gone to 1 micron side cut also, and it works well. So you can reduce the side cut. When you reduce the side cut, the base tissue, the amount of tissue removed also kind of reduces. So in thinner corneas, you can use almost like a 0 or 1 micron side cut. The other platforms don't have a side cut because of the patent issues. They are not able to have a side cut. So they overcome it in different ways. With the silk, it's like a biconvex lenticule. With Zemer, again, they have 2 incisions, and it's the way the incisions are shaped, even with ATOS. So they meet, and then there's almost like a 0 thickness side cut. Now, when do you increase the side cut? You can increase it to 20 or 30 microns when you have very thin lenticule. Suppose you're treating 0.75 or 1 diopter. So per diopter, Mullerlin's formula for 6 millimeter zone, it just takes 13 microns. But again, we have found in Calyx, suppose the two cuts, the superficial and deep, are very close to each other. Then what happens is, first with a smile, you make the deep cut, the refractive cut, and then you make the cap cut. So when you make the deeper cut, there are air bubbles, and that distorts when you're cutting the superficial plane if it's too close, and it can cause irregularity, and the visual recovery is not that good. So what we found is, if you increase the diameter of the lenticule to 6.5 or 7 millimeter, then the central thickness increases. And you can increase it to minimum 30 microns. So what we have found that ideally there should be at least 50 microns difference between the superficial and deep cut, so that you don't have this irregularity when the cap cut is happening after the lenticule cut. So you have a smoother interface and the visual recovery is better. So that is the reason why you have the side cut. And but of course, you can even use if you use a larger zone, then you can have a thicker lenticule.
Okay,
Basically,
sir.
that's what I showed you right from the beginning. What happened was that you are wanting to start the second cut right from the center rather than go from outside in, because that gave the time for the OBL to expand, and that caused the irregularity. In the in the silk platform, you can go over the side cut again and again to get into a deeper zone as you do in the flap. So that's something that you have in the silk so that you get good side cuts.
Okay, sir.
Sir, I
Thank
have
you, sir.
the last question posted on YouTube by a resident. Can we adjust the lenticule thickness in periphery for easier lenticule extraction in silk and clear like we do with Visomax 800?
Like I said, the
You
Visumax
cannot.
800 has a patent on this, on the thickness of the side cut. So the other companies are not able to offer that. So you can't increase the minimum thickness of the lenticule. That is fixed in the other platforms. Only on the 500 and 800, you can increase the thickness of the side cut. And
Otherwise,
by increasing the thickness of the side cut, of course, it is easier when you have very thin lenticules. Sometimes there is a risk of lenticule tear, especially if your energy levels are not optimized, if you have OBL or black spots in the periphery. So by increasing
okay.
So as we all know that audience are allowed to post any questions to iFocus team, and we'll try to get back with the answers. And we discuss all the questions with our experts and we answer all the questions. So residents can post any question to us. We welcome all the questions. And any other questions for in the house for the sirs? I think all the questions are over, and we will email you the question if we get some question which we cannot answer, sir.
Sure.
Yeah. So we appreciate the time and effort you put into sharing your knowledge with us today, sir. I'm sure everyone has gained valuable takeaway that they can apply in their own practice. Once again, thank you for being with us. And we would like to call the session today. Thank you very much.
Thank you, and
Thank
good
you.
night. Thank you very much.
Good night. Thank you.